Okay, can everyone hear me? Good morning. Welcome to Winship Grand Rounds. It's my absolute pleasure today to introduce Dr. Gregory Beatty, who comes to us from the University of Pennsylvania. I've known Gregory for quite a few years through a variety of going to the same cancer immunotherapy meetings, one of which was a regional meeting when I was at Ohio State and he was still at UPenn. You get to know people in small groups and the science that they're doing, and without a doubt, he is one of the people that has really risen in the ranks in the area of pancreatic cancer immunotherapy. And our group and many others throughout the country and even the world have been very tuned in to the findings coming out of his laboratory. He's one of the primary examples, I think, in the field of someone who legitimately takes something from bench to bedside and back again. He had a number of very important observations related to immune suppression in pancreatic cancer, and really what really kicked it all off in 2011, a science paper that showed CD40 agonists have efficacy against pancreatic cancer. He was later the first person to take that into a phase 1 clinical trial for patients, and from what I understand, that work continues to percolate and is ongoing. He's had other sentinel findings related to cytokines like GM-CSF derived from pancreatic tumor cells and how they tune the host tumor microenvironment. And most recently, he's published a manuscript that's really the first phase 1, I think, in pancreatic cancer using mesothelin-targeted CAR T cells for therapy of cancer. So really spanning everything in the continuum from targeted molecules to immune agonists, all the way now to adoptive cell therapy, and part of an excellent group. He's leading translational research for pancreatic cancer at University of Pennsylvania. Aside from his bachelor's degree, I believe, at Bucknell, he's been at UPenn for residency, fellowship, and now he has his own very productive and active laboratory doing cutting-edge research. So it's really my honor and delight to welcome Gregory here today and share his work with Winship. Thank you.
Well, thank you very, whoops, I'm gonna turn this on. That'll help. Can you all hear me? Whoa, there we go. Okay, you can all hear me now. Thank you very much for the invitation. It's a real honor to come down here and first time to Atlanta, so that's pretty cool for me. First time to Emory, and so it's been a real joy meeting with everyone last night, and I look forward to meeting with you guys today during meetings. I think Greg said quite a bit. I should summarize really what my talk is going to be about. I think what he missed is the fact that I became interested in pancreatic cancer back in 2007, and at that time I really thought that I was going to work on colon cancer. Pancreas cancer, there was about 30 to 35,000 cases a year, and the incidence and death rates kind of matched each other. But it wasn't really, in my mind at that time, such a significant disease. But I think what we've all appreciated, these are just some disclosures, is that pancreas cancer is really on the rise, and it's headed to become the second leading cause of cancer-related deaths in the United States. And so this has become a major health problem in the cancer field, and I think there's really two things that really kind of stand out on this, and that I hope to talk about here and shed some insight on, which is therapeutic resistance. This is a profoundly therapeutic resistant disease, and its propensity to spread very early. And I think those two things combine to make this a very difficult cancer to treat, among many other variables, including the performance status, the age of patients, the location of the disease, and comorbidities that patients have. Part of this is due to the fact that pancreas cancer really spreads very early, and so most patients will present with an insidious onset, and at the time of diagnosis will have distant disease. And of course, you'll be well aware of the fact that for patients with metastatic disease, overall, regardless of really the organ sites, we are not very good at producing a long-term survival in these patients, and that's particularly the case for pancreatic cancer. And there really has not been much improvement in that over the last 10 to 15 years. And that's despite the fact that we have made some improvements in chemotherapy regimens, right? We have now more effective regimens such as FOLFIRINOX and gemcitabine and Abraxane, and these are our standard of care that we shoot for when a patient comes into the clinic. I think one of the problems here is that what you see is there's really not an effect on the tail of these curves, and so there's a response rate and there's an early effect, but that is not sustained, and that'll be one of the themes that I want to touch on. And so as we think about moving forward in terms of other types of chemotherapeutic regimens that might be effective in pancreatic cancer, there are more that are coming forward, and we're seeing that the overall response rate is increasing, and a promising one that's been shown by the group down in Arizona with Dan Van Hoff and others, with gemcitabine, Abraxane, and cisplatin can lead to a really quite remarkable response rate, 60 to 70%. It's in a small group of patients, though. And I think what is still going to be appreciated is the fact that we're really just shifting this Kaplan-Meier curve to the right. We're not really affecting that plateau. And that's in contrast to what one sees with immunotherapy across other malignancies now, where the effect of immunotherapy is really shifting that curve upward. And that's what we'd like to be able to do in pancreas cancer. And I think we're starting to learn some of the variables that are involved in maybe doing that, but we're still not there overall. This was a recent abstract at ASCO that my group was involved in terms of the correlatives. And it's a phase 2 study combining gemcitabine and nab-paclitaxel or Abraxane with an endoximab, inhibitor of the IDO pathway. And the point of this slide is not really to focus on the endoximab, but really just to focus on the fact that when you look at this, there are clearly responses that take place, but the depth of those responses is really incomplete. Right? So there's much room to be had in terms of our chemotherapeutic regimens. Very few patients will go on to have a complete response, even though there's a pretty significant partial response rate. Right? The second piece is that the durability of these responses. Most of these patients came off therapy, and they came off of therapy primarily because of the reason of progression of disease. And if you look at, I think I missed one in here. There it is, treatment responses. I mean, you can see these treatment responses that take place, and by and large, they're taking place within those first 2 to 4 months, right? And if you look further beyond here, these are all plateaued out. So there's not a response taking place after that. And I think this is something that we really need to think about because our chemotherapeutic regimens are working initially, but the effect is not being sustained. There's therapeutic resistance, and so we're only beating up our patients with continuing to treat them with the chemotherapeutic regimens. This is a window of opportunity for testing other treatment options that could allow for a more deeper response and also to improve upon durability. So I think this is also a way in which we can think about how we stratify patients, right? Because each one of these is a different curve. They all have a very short durability in terms of the response, but there are distinct patient populations here. And one of the things that we contributed to this particular study on was trying to figure out what might be different between the responders and the non-responders. And so in this study, what we've done is there were patient biopsies, liver samples, largely liver biopsies that were taken at baseline and at the 2-month time point of the first imaging scan. And we analyzed them by immunohistochemistry, looking for largely just immune cell populations. And what we reported was that was really the CD8 T cell infiltrates that one can see. Now, T cells across really a lot of malignancies now, almost all, are associated with a better response to chemotherapy. And this is particularly the case in ovarian cancer. But in pancreas cancer, what we found here was that those that were responders at post-treatment, so at that 2-month time point, they tended to have a lot higher number of CD8 T cells infiltrating into the liver lesions. And they also tended to have a decrease, an increase in the CD8 to FOXP3 ratio. So what that's implying is CD8 are the effector T cells, FOXP3 are the regulatory T cells, and that ratio is being disrupted in favor of an effector T cell response, right? And so I think this points to the fact that what is going on around the tumor is quite important and may be predictive of outcomes and responses to therapy. And that is really what's led us down this pathway of trying to figure out how does the tumor grow in the context of the host? What is it about the immune system that surrounds pancreatic cancer that might influence, either in a positive way or a negative way, outcomes? And so what do we know about the immune reaction in pancreatic cancer? Well, we do know that there is a subset of the immune system that supports a poor prognosis, and that's these myeloid cells. And you can see neutrophils and macrophages, and they surround these nests of malignant cells that you can see here and there. And this infiltration of myeloid cells is associated with a worse prognosis. We also do know that there are T cells in tumors, and in particular in pancreas cancer, although most of these T cells tend to reside in very focal regions, and so they're shown here in purple with the malignant cells in brown. And the infiltration of T cells does correlate with improved outcomes, particularly for those patients who have undergone resection. And so having T cells present is a good thing. Having myeloid cells is a bad thing, right? But it's not just the mere presence of those T cells, because there are also studies showing that there really is no difference if you have T cells present or not in terms of outcomes. And what I think that really is trying to imply is that it's the location of those T cells within the tumor that's really quite critical. And there's been very nice work in colorectal cancer by Jerome Gallon and others trying to pioneer this concept of an immunoscore, which is really looking at the type, the density, and the location of T cells within tumors as a better predictive prognostic marker for patients with stage 2 and 3 colorectal cancer than the current TNM staging. And that was actually just really reported again this year, and I hope will change the way in which pathology views those types of specimens, and perhaps that will feed into the way we're thinking about other malignancies too. So in pancreas cancer, we see these distinct patterns. There's clusters of T cells. There's tertiary lymphoid aggregates where there's B cells and macrophages and dendritic cells all together. And we don't really quite understand what's going on there. And we also see these T cells that tend to be trapped within the stroma, this fibrotic reaction. And we don't quite understand who they are, why they're there, or what's actually trapping them. We do know that T cells tend to be excluded, and how you use the word exclusion, I think, is important, because you saw that they're in the tumor, right? But what I'm making the point here is they're excluded from interacting with the tumor. So they may be present, but they're not actually engaging. And a T cell that doesn't engage with the malignant cell isn't going to kill it through a perforin or Fas ligand or trail or TNF-mediated mechanism. It has to actually engage. We do know that if you take T cells out, and this is some work that was done by MD Anderson, that many of these T cells tend to have low reactivity to tumor. Now that might be because these T cells are hypofunctional, and there's work even 20 years ago showing that T cells in the peripheral blood and within tumors of patients with pancreatic cancer downregulate this protein, CD3 zeta, which is absolutely required for a T cell to become activated through the T cell receptor. So if you don't have that, you can't get activated. So now you have T cells present in tumors that lack this CD3 zeta, so they're not going to get activated. And in fact, there's also gene set analyses showing that there's a lack of a T cell activation signature as well. So I think all of these points are really coming to say that one of the things that we're going to have to deal with in terms of harnessing immune therapy for pancreas cancer is dealing with this functional paralysis that exists within the tumor microenvironment. So I think this is highlighted as well when you look at the effect of immunotherapy currently in pancreas cancer. So across a wide range of malignancies, antibodies that target the PD-1, PD-L1 pathway, which is a key regulator of T-cell effector function, has produced significant overall response rates. And in some GI malignancies, although GI malignancies tend to be less responsive, particularly pancreas cancer, such that the majority of patients are actually non-responders, right? And so that's not to say that PD-1 and immunotherapy hasn't changed the landscape of how we treat GI malignancies. Certainly pancreas cancer is the second leading cause of GI cancer-related deaths. And if you look across at where PD-1 therapy has fit itself into standard of care, there is a subset of patients with pancreas cancer for which PD-1 therapy does have some benefit. And those tend to be the patients with mismatch repair deficiency, those that have a high mutational burden as well. But I think it's fair to say that in terms, if you compare pancreas to melanoma in terms of immune therapy, that we're not seeing this continued increase in overall response rates with applying immune therapy drugs, right? By and large, if you look at the studies of single agent, you see that there's very few responses overall. And even if you combine, this was data that was presented in AACR, this past annual meeting in April, combining in an IDO inhibitor, in this case epacadostat from the Incyte Corporation, really had no effect. There were no responses. Now, if you start to add in chemotherapy, you start to see some responses. The question is, are those responses due to the chemotherapy? What role is immunotherapy actually playing there? Now, I did show you that gemcitabine, nab-paclitaxel, and edoximod study, and I think it's important to note that that was a negative study overall, right? Just about the same response rate as you would have seen with adding in PD-1. So I don't really think that there's much of response there overall. There may be some patients who do benefit, and we haven't yet figured out how to identify those patients. But certainly, I think in pancreas cancer, the one patient population that does stand out are those patients with mismatch repair deficiency. And there are, in that group, patients who respond to PD-1 therapy and have durable responses out past a year. So that's quite promising. I think it makes the point that perhaps immunotherapy can be applied to pancreas cancer. We just need to understand better what the elements are that are preventing it. And so much of what my group thinks about is those immune escape mechanisms. How does a cancer evade immune recognition? And we think of it in three ways. The first is antigenicity, so how visible or invisible are you to the immune system? So do you have antigens, proteins that can be recognized by the immune system, and can you even present them? The second is really propaganda. So how can you convince the immune system to stay away? So it's a mechanism of tolerance. And there are many ways in which pancreatic cancer can do so in order to form a cold tumor, one without very many T cells infiltrating and interacting. And finally is the microenvironment, is really the neighborhood, right? So you have to have a good neighborhood for these T cells to work in. And what I'm proposing is that these T cells are hypofunctional. The neighborhood's not good. So how can we improve upon that therapeutically? And so I think from a histological perspective, you can see these types of phenotypes. Certainly, if there's no antigen release from a tumor, you wouldn't expect T cells to come in, right? And so the T cells would be purple here, or sorry, brown. And the regulatory T cells would be purple, and you don't see any around this lesion, right? Even if you were to have a difficulty in terms of priming for an immune response and getting T cells in, you should see a lesion that lacks T cells, right? So you really can't distinguish on a histological basis these two mechanisms of potential escape, right? Once you get T cells in, I showed you an example that they can be excluded from interacting with the malignant cells. And finally, you can also see cases, and this is actually a lung cancer, where now T cells are directly interacting with the malignant cells, right? So that's an entirely different mechanism of resistance than this one is, right? The T cells got there, they're engaging, but they're not killing. And so I think understanding what are the variables here that are driving these levels of resistance is really important. If you compare pancreas cancer to lung cancer, that T cell immune infiltrate is also very different. So these are two examples of pancreatic cancer, one that has literally no T cells in it, and one that has actually quite a few T cells. But the contexture of that T cell response is completely different than what you see in non-small cell lung cancer, right? This one can respond to PD-1 therapy. This one does not, right? And I think there's aspects of this about this microenvironment that is going to help teach us about how do we convert a tumor that's like this into one that looks more like that one. And now that tumor may be more responsive to PD-1 therapy and other types of therapies. This is another example of pancreatic cancer. In the laboratory, we've been trying to develop strategies to combine chromogens to really visualize on a bright field level the immune response to pancreas cancer. This is a surgically resected pancreatic cancer, and a portion of it. And what I think you can appreciate from here is that there are distinct regions, and they're completely different at a microenvironment level. Right? So this region down here has a robust infiltration of T cells, whereas this lesion up here has no T cells. Even within the same patient's lesion, right? There's marked immune heterogeneity. And in fact, you might note that PD-L1, it's a little bit hard to see from here, but there isn't any brown staining. So, and in fact, Ki-67, when CD3, they co-localize, they should turn orange, and there really isn't any orange cells over here either. So they're not proliferating, they're not engaging the interferon pathway to drive PD-L1 expression. They're there, but we don't really know exactly what they're doing. And if you look across this tumor, you can see that there's multiple different regions, and it's really quite heterogeneous. So I think beyond just immune heterogeneity in pancreas cancer, there's also this therapeutic heterogeneity that I touched on a little bit that you can just start to define empirically. Patient populations, non-responders, stable, those patients that relapse, which tends to be the norm, and then the occasional patients who are a long-term responder. I think this is an opportunity, right, to be able to try to insert therapeutics in this region, and even here, to try to convert these now into long-term responders. They've had perhaps an initial response, but now how do we convert them into having durable responses? This is really, from an immune therapy perspective, the way we think about this is how do we shift this tumor from being T-cell cold to one that's T-cell hot, right? That's one way of thinking about it. I think from a medical oncology perspective, it's simply how do we take a tumor from treatment resistance and turn it into one that's now treatment sensitive. Even our standard cytotoxic therapies, which are still the mainstay, could be quite useful. And so as we've been addressing this type of question, how do you take pancreas cancer from one that's resistant to sensitive to treatments, we've looked at the microenvironments. And we've focused on several of these different components, but what I really want to focus on is really the inflammatory response and how that is a key mediator of this. And so I think in terms of inflammation, there's a couple ways to deal with it, right? You can try to deplete it, either block it from getting into the tumors, or literally try to kill the inflammatory cells that infiltrate. You can try to inhibit things that the inflammation is doing, that's shifting tumors to be treatment resistant, and that's promoting tumor growth. Or you can try to say, well, they're there. Can we leverage the fact that those inflammatory cells are going into the tumor? Can we harness them? Can we redirect them into anti-tumor inflammatory cells? And so I'll focus on each one of those elements. The first being that when you look at how cancer responds to our cytotoxic agents, it does so in a way in which it calls out for the inflammation. And that was seen in a work by David Tennardo and Lisa Cousins. If you look at breast cancer patients and you look at the inflammation, the myeloid cell component of tumors, you see them there, but after treatment with neoadjuvant therapy, there's many more. We went on to look at this in terms of radiation, and what we found is that you can treat even tumor cells in vitro sometimes, and they will start to release chemokines in response to the radiation that would call in inflammatory cells. And you can see that in mouse models, that the radiation induces an increase in macrophages, and that this is treating cell lines, that they will increase in terms of the CCL2, a chemokine that calls in myeloid cells. And in fact, if you take radiation here, which is this one here, there's a little bit of a response, but now if you block this chemokine, you can get a better response. So supporting the fact that malignant cells respond to cytotoxic stress by calling in inflammatory cells to help protect them. And the mechanism here really appeared to be promoting neovascularization after the injury, allowing for those tumors to survive and grow. The problem, though, I think that we're starting to learn is that when you disrupt one element of the innate immune response, this inflammatory reaction, that a compensatory reaction can take place. And this is work by David Linehan's group looking at tumor-associated neutrophils and tumor-associated macrophages. And here they give chemotherapy, and you see that there's neutrophils in the tumor and macrophages. And if they block this CCR2-CCL2 interaction, which recruits myeloid cells, then you see a decrease in the myeloid cells. But you will see an increase in the neutrophils. And it's only after you block both the neutrophil recruitment through CXCR2 and the myeloid compartment through CCR2 that you start to see a decrease in both populations. And they made the point that when you do that, now you start to see an increase in T cells, both in the absence of chemotherapy as well as in the presence of chemotherapy, and that correlates with the best overall survival in an animal model. And so there appears to be this compensatory interaction that takes place. This was also shown by Dmitry Gavilovich's group, where in this case they used a CSF1 receptor inhibitor to reduce macrophages within tumors. And what they found was that that effectively did so in multiple different implantable tumor models. But what you find is an increase in the neutrophils after that treatment. So there's, again, a compensatory increase in neutrophils when you target the myeloid compartment. And what they went on to show is that if you use the combination therapy, that works better than either therapy alone, and that now allows for PD-1 therapy to be more efficacious. So compensatory inflammatory reactions can exist when you target one path or the other, and what they thought was going on is that the tumor cell is releasing CSF1, which actually acts on the fibroblast to suppress its release of chemokines that would otherwise call in the neutrophils. And by disrupting this pathway, now these fibroblasts actually go on to release chemokines to pull in the neutrophil compartment. And so I think it's really quite remarkable how resilient these tumors are. You hit them with one thing, right? They adapt and do something different. They have a way. It sounds very much to me like HIV, right? And single targeted therapy did not work there, right? It's not going to work here either, right? In pancreas cancer, we need to think about it in terms of how tumors react. This type of finding, though, has some merit in terms of we think about patients. And this was a study that was reported out at SITC this past year, and some updates in terms of tumor biomarkers at AACR or ASCO this year. And what this was taking patients with chemorefractory pancreatic cancer and treating them with an antibody against CSF1 receptor, which is depleting. It depletes those cells, and combining that with PD-1 blockade. And so these are patients that are only getting two therapies. Neither one is cytotoxic, and neither one directly targets the tumor. And yet there were 3 or 4 patients that responded significantly to this therapy. I think this is encouraging, right? That you can take a patient with pancreas cancer and induce an immune response that can be, in some cases, quite significant. These are quite durable out in time. The biomarkers that have looked at this have shown that these are not mismatch repair deficient patients, and actually the tumor mutational burden was actually low. And so it doesn't fit those two variables that we otherwise would have predicted that these patients would have been. And so I think that's also quite encouraging that the immune reaction can be harnessed. Now, we don't know what the prior therapies that these patients did to potentially shift the tumor microenvironment in these patients. And so those are ongoing studies to try to understand what role chemotherapy has in this as well. But I think this is pointing to the fact that, and we've known this for a long time, right, since 1995, that inflammation is a critical component of outcomes in pancreatic cancer. C-reactive protein, a protein that's released from the liver in the setting of inflammation, IL-6 will drive it. High levels of CRP correlates with worse prognosis, right? And of course, I stole this from Greg Lazinski in recent reports that he and his group had in Guts, showing that IL-6 is released within the tumor microenvironment. And predominantly here, I think you can see the STAT3 pathway, which is downstream of IL-6, is activated in these tumors. And so there's an inflammatory reaction that takes place within the tumors. You can see IL-6 is elevated within the peripheral blood of patients. And in fact, if you take the plasma out of these patients and add it to monocytes that are circulating, you can show that the STAT3 pathway gets activated. And so systemically and within the tumor, there's an inflammatory reaction that's taking place. And so we started thinking about this using a mouse model of pancreas cancer that incorporates KRAS and p53. It's a spontaneous mouse model. We've developed cell lines from this model, and we looked for STAT3 phosphorylation as a marker of that IL-6 activation pathway. And we found that, yes, indeed, you can find both the stroma and the tumor show STAT3 activation. And if you come in with an antibody against IL-6 receptor to block the ability of IL-6 to signal, you can diminish the amount of STAT3 activation, although you don't reduce it completely. And in fact, if you take mice that lack IL-6, you also don't completely diminish the STAT3 activation within tumors, indicating that there are other pathways that can activate this pathway, this STAT3 signaling pathway beyond IL-6. And that's just quantified here. We hypothesized, though, that this may be a mechanism by which tumors could evade they could develop therapeutic resistance. And so we combined anti-IL-6 receptor with chemotherapy, and this just shows that in terms of proliferation, that IL-6 receptor did diminish some of the proliferation of tumor cells within the animals, but really no impact on cleaved caspase 3 as a marker of apoptosis. It was really the combination of IL-6 receptor and chemotherapy that led to both a decrease in proliferation and an increase in cell death. And so we tested this in a spontaneous model of pancreas cancer, and we found that the combination also led to treatment responses. And what we think is going on largely here is that IL-6 receptor, which actually isn't on the tumor cells, is actually getting shed from the myeloid cells as they come into the tumor. And then that's engaging with GP130 on the tumor cell to allow those cells to now be responsive to IL-6. And where this IL-6 receptor blocking antibody is taking place is preventing that trans-signaling process, and thus converting a tumor from chemo-resistant to one that's chemosensitive. This has somewhat translated into a clinical trial. This is a JAK1 selective inhibitor. So JAK1 will target the IL-6 pathway, but it will also target multiple other pathways. And that may be part of the problem as I show you some of the data, is that it's not completely selective to IL-6. But this was a study that we contributed to at Penn, combining gemcitabine and nab-paclitaxel with JAK1 inhibitor. And this was largely in pancreas, breast, and lung cancer. There was a whole cohort that was just pancreatic cancer. And I just want to show you those patients here, and that's, there were significant responses. Overall, though, the response rate was pretty similar to what one would have expected with gemcitabine and nab-paclitaxel alone. And so this compound was, in the trial, was actually stopped. It was stopped at the same time that a second set of phase 3 trials were underway looking at a non-selective JAK1/2 inhibitor called ruxolitinib, which was used in combination with capecitabine, a chemotherapeutic, across multiple other European countries, and there was really no difference between giving chemotherapy alone versus chemotherapy and the JAK inhibitor. And so that was withdrawn. And I think, as one reflects on this data, one thing to consider is the fact that this is not targeting just IL-6. It's targeting multiple signaling pathways. In fact, it's even targeting T-cell signaling pathways, which may be pretty critical to this. There is an ongoing study now, and we talked about this last night, how hard it is to get tocilizumab into the cancer community. It's largely a drug that sits in the rheumatology division. It's the company who owns this. But there's a Denmark study that's going to actually do the study that we would have wanted to see done. And then I heard encouraging news that this is a study that will make its way now into humans, and I think makes the point that combining therapies that target IL-6 and PD-1 may actually have merit as well. And I think these studies, as I recall, were largely done in BRCA2 mutant mice. And so that DNA damage repair component may have a significant impact on seeing efficacy with this particular therapeutic combination. It's just a thought to consider. So as we come back to this, we've talked about depleting, inhibiting, redirecting is another potential way of doing this. And as Greg mentioned early on, one of the things that started my work was, this somehow died off. You can't see the scale here. But at any rate, CD40 is a molecule that we've studied quite a bit, largely as a tool. It was discovered back in 1986. It was found to lyse antigen-presenting cells. And it does so by inducing the expression of co-stimulatory molecules on these antigen-presenting cells, and that can help to drive effector T-cell responses. And so it was then shown that you could deliver an antibody that targets CD40, and that could then induce an effective T-cell response in patients, in mice. And the first in-human clinical trials took place looking at single dosing, weekly dosing. And I think what has really come out of this is that by itself, a single agent is not going to work here. There's really not much a way of an overall response rate. And so that's led to multiple trials now that are trying to combine CD40 agonists. And if you look back, there's been in the literature, there's been quite a few studies looking at ways in which to combine CD40 agonists and another drug. And what you'll notice is that most of these are actually implantable tumor models. And this is just a reminder for me to say that one of the things and we study implantable tumor models in the lab, but one of the things to always bear in mind is the fact that putting a tumor under the skin is a vaccine, right? It induces an immune response. And so really what a lot of these studies are looking at is the ability of a CD40 agonist to boost an existing immune response. And of course, if you look closely at those studies, most of them have treatment beginning at day 3 or day 7 after implantation, which means that you're really just boosting the vaccine response that you're delivering to by putting the tumor under the skin. Many of these all have a T-cell based mechanism. It's interesting that when you start to delve into the genetically engineered mouse models, this one here that I'll show you a little bit about, as well as this one which was recently reported in GIST, those are actually myeloid based responses. So a big difference between the model and the mechanism of action that is actually seen. We've studied much of the therapeutics that I'll show you here towards the end in this KPC mouse model that incorporates KRAS P53 that's targeted specifically to the mouse pancreas. So these mice develop pancreatic cancer that looks very similar to what one sees in human pancreas cancer. This just shows that the T cells tend to lie in these lymphoid aggregates outside of the tumor. You do find a few T cells that will infiltrate, but they by and large have that exclusion effect that you see within in human cancer as well. We've developed several cell lines and different models to be able to use this. Our first clinical trial in the mice was really trying to combine CD40 agonists with chemotherapy. At the same time, there was a clinical trial going on in patients. And so we tried to mirror that. Mice were followed for their tumor development, which occurs in the pancreas now, with ultrasound, and then they received chemotherapy, followed 2 days later by a CD40 agonist, and then repeat of chemotherapy. And this was all based off of work by Anna Nowak's group in Australia, where they showed that giving chemotherapy and prior to a CD40 agonist led to long-term survival and outcomes in a mesothelioma implantable tumor model. And so we copied that treatment approach both in the mice and in the patients, and we found responses. We found this is a change in response, change in tumor volume relative to baseline. You can see some responses here in the combination group, and we saw some responses even in the CD40 agonist group alone. And when we depleted T cells, we actually still saw the responses. And so that was unexpected. When we went to the patients, we also found a very similar type of finding. Patients were treated with chemotherapy, then a CD40 agonist, and then repeat chemotherapy. There were a few responses. This was more than what we would have expected with gemcitabine alone. And some of these responses were quite remarkable. So this is a patient who had 2 liver lesions at baseline, and one of them disappeared completely. The other one shrunk by about 50%, and even the primary tumor shrank, which was atypical for gemcitabine alone. But when we biopsied both of these patients, this one went actually to surgical resection, we didn't find any T cells. It was largely myeloid cells within the lesions. And so that was a bit unexpected, again, and led us down this pathway of trying to figure out if macrophages might be involved. And so we depleted macrophages with our mouse model, and we found that the responses were lost, indicating that macrophages were absolutely required for this therapeutic effect. And we could take those macrophages out of the tumors and show that they could kill tumor cells in vitro as well, after having seen the CD40 agonist. And so this has led us to try to figure out, well, how did you shift macrophages from being pro-tumor to anti-tumor? And one of the things I think that is really quite important is that there's a transient cytokine release that takes place within 24 hours after treatment, both in the mice and in the patients. And a key component of that is interferon gamma. And we've known for years, right, decades now, that interferon gamma can shift macrophages into an anti-tumor phenotype. We also found, interestingly enough, and I think this will be important moving forward using CD40 agonists, is that T cells that were taken out of the peritumoral lymph nodes of the mice after receiving CD40 agonists were more functional. They were capable of secreting cytokines than the T cells of animals that had received control treatment. So somehow CD40 agonists may be recovering some of the functionality of T cells that's otherwise lost in patients, in our little patients, the mice. So, how does CD40 agonists work to do this? Well, one of the things that it does is we found that it very rapidly gets into the tumors within 18 hours, but not within 10 minutes. And that infiltration of the antibody into the tumor is absolutely dependent on macrophages, because if you deplete the macrophages, you don't see the antibody go in. So it's carried in. That's how it gets in. So that means that the activation is taking place outside of the tumor. And one of the things that we found within 18 hours of treatment was that there was this marked depletion of matrix elements, in particular type 1 collagen, and that macrophages were absolutely required for that depletion effect. There are multiple different types of myeloid cells that exist within the peripheral blood that could potentially traffic in. There's inflammatory monocytes that express high levels of this chemokine receptor. Those are the monocytes that we typically think about in terms of promoting tumor growth. They're the ones that go into tumors in the setting of chemotherapy and radiation and drive tumor growth afterwards, right? But what it turns out is we found that those were the monocytes that were going into the tumors, right? So this led us to believe that there may be some sort of phenotype change that takes place in those monocytes as they enter. And what we found was that if you deplete those monocytes using a Ly6C antibody, that you lose that anti-fibrotic effect that you see within the first 24 hours. And that's just quantified here. And in fact, those monocytes, as they go in, show evidence of having been activated by the interferon pathway. So they have phosphorylated STAT1 that you can detect here, and if you block interferon gamma, you lose that red signal here. That's phospho-STAT1. And in fact, if you block interferon gamma and you neutralize it, you lose the anti-fibrotic effect. So here, that cytokine release that takes place very early is critical for changing the phenotype of those myeloid cells as they come in. This creates a window of opportunity, though. You've changed the microenvironment. The collagen, the matrix there has been altered. It stays down for about 7 days, right? And you can see that quantified here. And so we hypothesized that at the same time there was work coming out that the matrix can be a physical barrier to delivery of chemotherapy. And so we said, well, by modulating that matrix, are we now shifting these tumors from resistant to sensitive to chemotherapy? And so we tested that, and what we found was that chemotherapy alone really has little effects in terms of inducing necrosis and little effect in terms of impacting proliferation of the tumor. But if you pre-treat now with a CD40 agonist and you come in 2 days later or 5 days later, now you see necrosis, and now you see a significant level of decrease in proliferation. And if you look at just CD40 agonist alone, you don't see that effect at that particular time point. But there ended up being a problem. And the problem was that when you look at this day 2 time point and you look at the animals, it turns out that they're actually starting to lose weight significantly. These animals are not doing well. They have liver toxicity. But one of the encouraging findings here was that if you wait 5 days and then give the chemotherapy, the animals do just fine. And that, it turns out, was exactly what we did in the clinical trial. We just didn't know we were doing it, right? And so we were lucky. And so if you look here, you can still see the same treatment benefits. And in fact, the combination therapy is better than either therapy alone in terms of controlling tumor growth. So what I think this tells us is that there are 2 ways in which you can sequence immunotherapy with chemotherapy. You could put chemotherapy first and then a CD40 agonist, and this should be T-cell dependent. It has actually limited activity in a spontaneous model, and it works really quite well in an implantable tumor model. And of course, the benefit is that you would get immunological memory out of that. But if you think about it, and for our patients, we really want to have get some sort of tumor control over them. We want to debulk in many cases, and so having a macrophage-dependent mechanism might be just fine. And this is now giving CD40 then chemo. It's active in the spontaneous model. It's also active in a implantable tumor model, and it would be good for tumor debulking and control. And so it turns out that all we're really saying here is to remove that chemotherapy. It really turns out to be quite simple, right? And why would that be so important? Well, if you look at what chemotherapy does, it causes a rapid decrease in the myeloid compartment. And I just showed you that myeloid cells are really important. They have to go into the tumor. They have to mediate that anti-fibrotic effect. And so why would that also be important? Is because CD40 causes bone marrow mobilization. And so you don't want therapies disrupting what you're trying to harness for therapeutic benefits. We've also learned out of this study that combining a myeloid agonist and a myeloid depleting strategy could be counterproductive. So incorporating anti-Ly6C actually negated all of the therapeutic benefits of giving CD40 prior to a chemotherapy. And we've recently developed some data showing that this also holds true for TLR9 agonists in our mouse model. So giving a TLR9 agonist actually leads to a stasis in tumor growth and a little bit of a tumor regression here. And if you deplete with CSF1 receptor inhibitor, you entirely completely lose that therapeutic benefit. So how we put drugs together, I think, is really critical here. So I think I have about, what, four minutes or so? Is that about right? So I think in the interest of time, I will go through just a few of these things. The first is to say that, as you start to think about the how do you harness T-cell immune response in pancreas cancer? We've worked on vaccines. Vaccines have been tried in pancreas cancer, and by themselves, they've largely been a failure. There's been efforts to try to use CTLA-4 and CD40, and those are ways in which to release the brakes, and PD-1. CAR T-cells is another approach, and I just want to show just a little bit here. So CAR T-cells have worked really well in hematological malignancies. They've not worked so well in solid malignancies. But there have been some interesting responses, and I think they do tend to be a nice tool. And one of the reasons they're a nice tool is because of the fact that you can bypass this whole vaccine issue, right? And just start with deliver the T cells. You know they're reactive against the tumor, and put them in and see what happens. And when we've done that, we've engineered a CAR that recognizes mesothelin, and it includes a 4-1BB and CD3 zeta signaling domains. They're quite active in vitro, and they'll kill tumor cells quite well in the tissue culture. And when you put them into patients, though, what you see, these are 6 patients that were treated with CAR T cells, weekly infusions for 3 weeks, 3 times a week. This patient here with pancreas cancer has a remarkable number of liver mets and a primary lesion in the pancreas. And 1 month after treatment, there's a complete loss of the activity of FDG uptake in the liver. And so the only thing this patient received were the CAR T cells. It had an effect, right? But the patient died very shortly after that, in part because you can see the primary lesion didn't respond, right? So I think one of the things that this teaches us, not only the fact that CAR T cells by themselves is not going to work in pancreas cancer, most likely, unless they're engineered in some sort of specific way, is that there's mixed biology that exists between lesions, between sites. And we've seen this before. We've actually seen this in the context of the phase 1 study that I was showing with gemcitabine and CD40 agonists, where each lesion we looked at, and some lesions responded completely, some lesions didn't respond at all. And you could see that here, that the green arrows show responding lesions, and the red arrows show lesions that don't respond. And so what have we learned overall? I think that monotherapy by itself is not going to be efficacious in pancreas cancer. There's a couple of areas where this might work, but we need to think strategically about how we're combining therapies, how we bring them together. We do know that we can induce T-cell responses in patients, and even chemotherapy may be helpful in being able to do so. And I want to end here, I think, with a couple summary slides. I'll skip over a couple slides here in a moment. But I think one of the points here is that where the field lies in terms of pancreas cancer right now is really trying to shift tumors into those that are going to be chemotherapy sensitive. And so there are studies looking at this in combination with CSF1, FAC, CCR2, CD40, and ways in which you can shift tumors so that they're more responsive to immune therapy, largely in terms of PD-1, to get regressions. And most of these revolve around this theme. It's deplete, inhibit, or redirect the inflammatory compartments. And so I want to just, well, I'm not going to be able to do that. I'll just go through. There was a little bit here that I wanted to talk about. So one of the ways that we think that this should actually happen is that in terms of harnessing a T-cell response is that chemotherapy can be useful in terms of inducing an immunogenic antigen availability, that one will need to condition that lymph node, that priming microenvironment, to get a T-cell response going. One way to do that is to bring in CD40 as an agonist. And then finally, as you start to get T cells that infiltrate into tumors, that's when you start to think about the PD-1 and those types of therapies. I think we're actually at a point where PD-1 is just, pancreas cancer is not quite ready for PD-1 in many ways. We have to be thinking about how do we get the T cells in, how do we get them activated, and once we have that activation signature, now it makes sense to start layering in those types of therapies. And so the points that I wanted to make out of this, this talk is that prior treatment history and tissue reprofiling may be used as a way in which to try to identify, so that's looking at the empiric way of identifying patients. There can be many obstacles that exist. Talked about the microenvironment and tumor heterogeneity, but one of the things that we haven't talked about really is cachexia, right? The hypercoagulable states, malnourishment, how this may impact the immune fitness of the patient. We do have data showing that the immune fitness of T cells is quite decreased, and that's consistent with what I showed you in terms of the hypofunctional state of T cells in this disease. You can stimulate T cell responses, though, in patients, but it's really the quality of that response that's important. Pancreatitis drives tumor progression, right? That's inflammation. That's the immune response. So having the right kind of immune response will be quite critical. And I think one of the things that is emerging here is these compensatory mechanisms of resistance that can exist. And then we have to think about how tumors adapt. There are strategies for using immunotherapy to promote T cell immunity, but also immunotherapy can be used to enhance chemotherapy efficacy. And I think that's an important way of thinking about this, how immunotherapy may be applied to pancreas cancer. There's certainly significant response heterogeneity, and we see that across multiple different types of lesions, even within the same patient. And I think there's much to learn there still. And data that I didn't actually show is that we have data showing that you can target just the myeloid compartment in pancreas cancer without hitting the T cells, and that's sufficient to drive a T cell response independent of checkpoint inhibitors. So there may be even ways to get around using checkpoint inhibitors, which have the adverse events issues that are of autoimmunity. And then lastly is that strategic combinations and ways in which to sequence. And so we've been thinking about this in terms of how do you induce a tumor, an induction phase, a consolidation phase, and a maintenance phase. Very similar to what our hematological malignancy colleagues think about in terms of leukemia. And the way I see this is largely that, here's pancreas cancer currently when the patient comes in. How do we shift that disease from one state to the other in order to put it now into a state that might be similar to a lung cancer or a melanoma that would be responsive to immunotherapy? And I think we need to understand each one of these steps and how do we drive, shuttle pancreas cancer into this biology where it can be eliminated. There have been many people who have worked on this, colleagues within the lab, postdocs that worked on the CD40 work, and Jay Lee, I didn't have a chance to show some of our liver metastasis data, colleagues at Penn, and within the cell therapy group with Carl June and Joost Mellenhorst, and then my funding. So I appreciate you taking the time to come and listen, and thank you very much.